Thank you so much for joining us, Dr. Javaid. Whenever you want to go ahead and get started, but no rush.
Thank you so much for inviting me. And as you guys can tell, I am not Dr. Woods, slightly different. And I am her counterpart in from Mount Sinai, Brooklyn, and Mount Sinai, Beth Israel, as well as Mount Sinai downtown and Union Square and other places. And she and I work together in a lot of aspects, and I think she wasn't able to come, so she asked me if I can pitch in, and obviously I can. So and during this conversation, if you guys want to discuss anything or clarify any point, please feel free to do so. I would rather have it more of a conversation than me lecturing on some topics. All right. So with that, we'll start. Our goals and objectives will be to discuss the reportable hospital-associated infections, know which hospital-associated infections are nationally reportable and which are locally, identify elements of the bundle that prevent hospital-acquired infections, and then talk a little bit about the PDCA cycle, define the financial implications of HAIs, and then reporting the impacts or reporting impacts of the HAIs themselves. These get very confusing, but I'll get into more details. But I want to start with a little conversation about two folks on this picture. Can people tell me who these people are? Anyone?
You can unmute or post in the chat. Mantej is saying Typhoid Mary.
Typhoid Mary, I like it, but no.
Maybe
thank you.
Nightingale?
Yes. You're talking about the person on the left, right?
Yes, I am.
Yes, that was a joke, but yes. All right, good. And who's on the right? So I'll give you a little bit of history. Both of them were born in 1808, 1810 time frame, so about 200 years ago. So one was Florence Nightingale. The other guy is Carl Semmelweis. Sorry? Oh, yes. Yes. Perfect, Semmelweis. So he and Florence both have been critical in infection prevention. Florence Nightingale was first person to identify that the illnesses that were killing more soldiers than the battle itself were infections acquired during the infections acquired during the battle. So the battle didn't kill as many soldiers as the infections that did. Mr. Semmelweis is also so let's see. Oh, I need to move this. Go forward. Here you go. Here you go. All right. So Semmelweis. Before we go there, Florence Nightingale, it may seem a strange principle to enact as this very first requirement in a hospital that it should do the sick no harm, which in my simpler English is we should not do any harm to our patients. So Semmelweis, or Ignaz Semmelweis, actually is called the father of infection prevention, although I think if he's the father, Florence Nightingale would be the mother. He actually did a lot of work. He was a physician who looked at two wards. He was an OB/GYN physician who looked at two wards where he found that the mortality in Ward A, which was run by doctors and residents for their postpartum infections and death, was about 30% higher than mortality in the Ward B, which was run by midwives. And upon closer inspection, he found that the midwives were actually washing their hands versus the doctors and residents were not. So he implemented the same principles across both wards and lo and behold, the infections minimized and completely got eliminated from as a cause of mortality, maternal mortality, or postpartum mortality. So most of you guys know that Florence Nightingale was a big name in infection prevention, but do you guys know what happened to Semmelweis, who told people to wash his hands? This is like for extra brownie points. I'll talk with Dr. Woods to give you a pass throughout your residency.
He was ostracized. Huh?
Ostracized. Committed to a psychiatric ward because of his claims that hand washing will help people. So he actually died within a few years of publishing his data because people told him that what his claims were wrong, and that's where we were in 1830-40 data. Now from then till now, we know the infection prevention basis is in hand hygiene, and doing hand hygiene is critical. We should do hand hygiene. You guys already know this. Regardless of touching the patient, if we are entering the environment, we should do it. It sometimes doesn't make sense. Why would I do hand hygiene? But it's critical and important to do hand hygiene in these situations because we don't want to miss any opportunity to do hand hygiene. This simple intervention has been shown to reduce mortality and improve outcomes, and also very recently, we have seen it clearly prevent infections in people who themselves are doing hand hygiene, for example, with the respiratory illnesses and whatnot. So we see this a lot, and people, myself included, when I was a little younger, I would wear gloves thinking that I don't have to do hand hygiene if I'm wearing gloves, but gloves do not replace hand hygiene. The only purpose of gloves really in most of the cases is to prevent any blood and body fluid exposure to our hands and any small wounds in the hands themselves. They don't really stop anything from transmitting from one place to another, from our hands on one patient to another. We need to change and remove our gloves between people. We need to remove our gloves on and wash our hands after we remove our gloves. And before we wear any new pair of gloves, we should always do hand hygiene. So the for Mount Sinai Morningside overall. So for Mount Sinai Morningside, the overall goal of hand hygiene is up to 92%, I believe, and you guys are as high as 95% on the recent month and the recent month observations. For what happens during these observations, and for the West, it's the goal is actually 95. That was 92 for MSM. West is 95, and they're as high as 100%. So what is the goal of hand hygiene? What should be the number we should be striving for? 100%, right? So 100%, but like there would be cases and people recognize if you are running to run a code, basically a situation is critical. Patient healthcare comes before everything else. So obviously that is the main goal, to protect our patients and save them. So you prioritize. So we don't expect it to be 100% all the time, but the goal almost always is that we should do it. How do I do hand hygiene, or most of the people in my field do it, is whenever I see a hand sanitizer, I use it. So if I see it on the wall, I test it. I put my hand under it. If the sanitizer comes, use it. It's fun, and also make sure that it's full. It's very interesting to know which sanitizers are full at what times. I keep a mental note of these things and amuse myself sometimes about these things. Like, okay, that, but also like if you find a hand sanitizer that's empty, what should you do? So you can let the unit clerk know, you can let the unit secretary know, you can let the nurse manager know. You should let somebody know that, hey, this one of these sanitizers is empty. It gets filled by different people in different hospitals, but EVS and other groups are involved in it. We should let people know that it's empty, so it can get circulated, and it's always helpful. So just to, quickly, hospital-acquired infections or hospital-associated infections include CLABSI, CARTI, and VAE, SSIs, and so on and so forth. But just a few definitions. HAI is a term we use a lot, and that term is basically used for hospital-acquired infections or healthcare-associated infections. Pretty much the same thing, but healthcare-associated is a little bit expanded definition of such. Hospital onset, anything that starts in the hospital, usually defined as 2 to 3 days into hospitalization. See, here I said 2 to 3 days and not hours. When I was a resident a few years ago, it was hours, 24 or 48 hours. They changed it to days. So I did make a joke right there. A few years ago, I was not a resident. I was still an attending. It's been a while. All right, so I'm just testing you guys how attentive you are and how many people smile at my jokes, even though they're bad, but that's fine. All right, so so what is CLABSI? Yeah, I like that. Now people are smiling and paying attention. All right, so CLABSI and CARTI. So yeah. Central line associated bloodstream infection is CLABSI. Catheter associated urinary tract infection, CARTI, and it's how you pronounce CARTI or CARTI is it's a debate on its own. I won't get there or go there. So ventilator associated event or VAE is another thing we monitor. I don't like that. I'll get into the details of that, but there are some definition issues. But SSI or surgical site infections is another metric that we closely monitor. But important points in infection prevention have been in 1970, CDC established what we call as NNIS system of surveillance. That was actually more of a reporting system. People in ICUs would report certain infections, and they established some baseline of what needs to be reported and when and how and where. That also was around the time first infection preventionist was hired, I believe, in Johns Hopkins. That's like very, very recent specialization. In 1990s, HAI surveillance program focused only on selected HAIs, but Pennsylvania's required in 2004 more facility-specific rates, and then actually 2011 is where CMS added ICU CLABSIs as first of several HAIs that required public reporting. In a few years after that, actually the CDC or actually CMS required or added hospital payments to reduction to performance in HAIs. So and I'll get to it in more detail, but they kind of establish certain rules that if you have more than certain level of infections, your payments will be reduced as a hospital. So what are the reportable infections? CLABSIs, CARTIs, hospital onset MRSA, bacteremias, not every MRSA, hospital onset bacteremias, MRSA bacteremias, and C. diff infections. And then SSIs, specifically colorectal and hysterectomies, are reportable to NHSN, which is the CDC established national network. And then additional for New York State, because we live in the lovely New York State, we have to report hips, spines, and cabbage as well, just because they want us to. But the bigger goal really is to make sure that the quality is well maintained with these infections. So for acute care hospitals, CDC estimates that hospital or healthcare-associated infections account for about 1.7 million infections, of almost 100,000 deaths. 3% of hospitalized patients get HAIs, and approximately 1 in 31 patients contract at least one HAIs. And that's really sad. So NHS and definitions can be pretty tricky, and it's likely not going to be in your boards. But there's a reason we want to discuss those a little bit with you, is that these definitions are surveillance definitions. These are not clinical definitions. These are designed specifically to be overly sensitive, to pick most of the infections so that they can be, so that they don't miss any higher number of infections. So if there is a central line and a positive blood culture, it's going to be CLABSI as long as the line has been in there for more than 2 days, calendar days. So before it was hours, so we don't talk about hours. It's 2 calendar days. Line has to be in there, and even after removal for 2 days after removal of the central line, if the blood culture comes out positive, it still can be considered a central line associated bloodstream infection. Even if I write it clinically, it does not make sense. The patient does not have any infection. I'm an ID doc. I bet my life on it. Surveillance definitions don't account for what I think, or an ID doc thinks, or anybody else thinks. They are standard definitions. Any questions on this? So certain strategies that are implemented on to prevent CLABSIs include cap changes. So these central lines have these fancy caps. It's very, very interesting from the time I was a resident a few years ago till now that there's been a lot of changes, including these caps are new things. The last few years, last 5 years, you've started to have these caps. We didn't have these things before. People used to have to scrub the hub. Is one thing we learned a lot, was to scrub all these caps, or do all these when you're entering the central line ports, then you need to scrub all these hubs, is what we would call. But we don't have to do as much because we have these caps that are CHG impregnated. So there's a lot of technology that just goes on these lines already. So dressing changes needs to be happening every 7 days. CHG bathing in anybody who's central line should be getting CHG bathing automatically on a daily basis. Dressing should be intact. The bio patch, which is a CHG patch, needs to be in place. Curous caps need to be in place. So you guys know the bio patch, the curous caps, the dressing itself needs to be dry and clean. And the scrub the hub before infusing the medication still is important, but it was the only thing we could do before, when we didn't have these CHG impregnated caps or alcohol impregnated caps. So certain times you'll see lines that are in questionable situation when the dressing is coming off because of the facial hair, especially the necklines, and those are not in good shape. Those need to be addressed, redressed, or removed, or relocated. Right? So the critically ill patient, you need to start planning. And that's really what the role of a provider or physician is to plan, right? So most of our work is obviously diagnose the illness, diagnose the disease, and then try to treat it. But all of that comes under a bigger umbrella of planning. Central lines, peripheral lines, catheters, all these things should be part of our planning. So if you see a line that like this, you should start planning on, what do I need to do? Should I remove it? Does the patient need a central line anymore? Can I convert these medications to peripheral? There's a lot of options. Midlines can be used. Does this person needs to be shaved, or should I put a PICC line? A lot of other options. So right line algorithm is in place in MSM, and I really like this algorithm. So if you're gonna put a line in for less than 6 days, Peripheral line is probably a good choice. So a person comes in, it seems like they have a pneumonia, community acquired pneumonia and all, can just use a peripheral line. You can potentially get a midline if the person is not doing very well in the next few days. You think the antibiotics or treatments might be prolonged. A midline is about 7 to 30 days. PICC lines should be also considered for similar at least 7 days, but potentially anything that's more than 2 weeks. So I think about it this way: if it is less than a week, I think about the peripheral line. If I think, and that's where your planning hat should come on, is if this person needs a line and there's no rule specifically, your experience will tell you or guide you, but you should always think about, okay, pneumonia treatment possibly this much long, maybe 7 days, maybe 5 days. Okay, still peripheral line would do. But if you think the patient has osteo, maybe you want to start with a midline and then think about a PICC line if it is confirmed, something like that. So you don't have to keep changing the lines as well. So any questions on what I've discussed so far? All right, so my rule of thumb is if you don't ask me questions, I start asking you questions. All right, so wait for it. I wait KOT. I have no idea what this joke is, but it sounds funny. Very funny. All right. I have no idea. I'm laughing. All right, so Kati. Oh, now I get it. That's what is KOT. All right, I'm gonna call that KOT from now onwards. Oh, I made it. Yeah. Oh, I killed the joke completely. My apologies. All right, catheters must be in place for greater than 2 days, or the urinary catheter should be in place for greater than 2 days, or it'll be considered to called a CARI or KOT. Still counts if any part of the day on which the culture was positive or removed the day before the positive culture. And that's the painful part. If you remove it today, the next day is still, the urine culture is still positive, it can still be positive. CARTs require fever and any symptoms, and hopefully less than two or less species of organisms, and greater than 10 to 6, 10 to 5 organisms. At least one of them should be greater than 10 to 5. In general, what should we think about when we see a patient with catheter? So first thing go ahead. Somebody was going to answer.
Do you want to know like how soon you can remove the catheter, or like what's the barrier for keeping it in?
Absolutely. So does the patient ever had a catheter? Like, I don't use a catheter normally. Some people need it, right? So majority of people, 90+% of people you will encounter in the hospital will not have a catheter. So that's a good point. Like, you don't want to, like, the catheter, having any catheter, central or peripheral line, and urinary catheter is not normal. We don't walk around with urinary catheters, right? It's actually considered by some as 1-point restraint because it is a restraint, right? So you need to think about it as a barrier to life, not even discharge. That's a secondary thing. We need to get our patients back to their normal life as quickly as possible. That's, as doctors, as basic role of our life, right? So we need to get them back to whatever normal life they whatever life they had, as normal as they can have it. It doesn't have, like, being in a hospital is not normal. We need to get them back to their normal life. Catheter is a problem. So first question we ask is, why does this person has a catheter? When I was a resident, apparently I was not a good resident apparently, because I look back at myself, I'm like, really? But I sometimes didn't even recognize or realize my patients had Foley's, right? It became part of the background. Right now, doing infection prevention for this long, I recognize that we need to put it forward. We need to actively look for it. So we get very busy during our day-to-day work, and sometimes we don't look at the background of the patient has a Foley or peripheral line and all that. We need to question every device the person has. That's the way to prevent all these infections from all these various lines and catheters. So how many people know for all their patients that how many people know among all the patients they have today, how many people have Foley's? The answer could be 0. You might not have any patients. That's fine. All right. Just think about it. I don't want the answer specifically, and there's no reason to give the answer here, but just think about it, because I question that to myself every day now. So how many patients I saw today had Foley's, and did they need them, right? It's easy. Keeping the Foley in is easy. And I tell this to my resident fellows all the time, it's easy to keep the Foley in, it's easy to keep the antibiotics going. It's hard to stop the antibiotics, and it's hard to remove a Foley, just because it requires a lot more thought and a lot more effort. And also sometimes we don't want to change the Foley. Sometimes the patient doesn't want to remove the Foley because it's easy for them. So part of it is that we need to make an extra effort to talk with the patients, tell them that this is bad for you. Just like we tell them that these extended antimicrobials are bad. These are more harder conversations. So quality prevention is complicated. Urine becomes contaminated with organisms within hours. Within 24 hours, urine can start growing organisms in a Foley catheter. If you keep urine in a cup, after 4 hours, it might actually start growing organisms, just because it's just the nature of how the urine is collected. One thing I ask everybody is, what is a clean catch? What is a clean catch? So it's a midstream urine, right? And there's some other elements, but it has to be a midstream urine. A 90-year-old admitted in the hospital, getting a midstream clean urine from that person is almost impossible. But if you look at the orders and culture results, sometimes you say, see, clean, it's a clean catch. I'm like, how did you manage that? I would love to see that. It requires cleaning the area first and all that. So you need to think about how challenging these situations are. Now, how do we do that? Because so if you do culture through the Foley, that's another problem. But looking at the prevention bundle, you look at insertion, skewering, the drainage bag, the hygiene. Then you also look at the alternatives, indications, need review, and the families. Once you start looking at these things from more holistic view, it becomes very easy to look at that these things are not right. This is an overfull bag, and this other bag is I don't even know what is going and how. Another way of looking at it is, it should be skewered really nicely, but it should really not be touching the floor like this. It bends and causes problems. One thing I see sometimes is people are walking around, and this is very long, fancy algorithm that you guys can look at, and I can take you along with this. But for people with urinary retention, you obviously put a Foley, but you have other options as well. If the Foley or a catheter is in place, is there another indication for the catheter? If none, then you remove the catheter and test. If there is, then you look at every time you review, you look at why the catheter needs to be in place or not. There are other modalities. You look at how many, what's the urine volume. You can do bladder scan before you place the Foley. If the volume is higher than 300, what are the other probabilities? And like Fatma said, yeah, straight cats are possibilities and options. You can consider all those options as well, or hydration, so on and so forth. You know, in 15 plus years of my medical career here, I have yet to see a bladder explode. But urinary obstruction, so people start fearing if there's a lot of volume, the bladder might get ruptured and all that. It doesn't happen. What does happen is the kidneys get affected, and we do have kidney failure. So we need to prevent that. It doesn't happen immediately, but you need to make sure that the urine is flowing outwards and not staying inwards. So you need to kind of keep an eye on and keep it moving. But some people, like I remember a lot of conversation I had in the past was like, oh, the bladder is so full, so full. Well, it's not the bladder. It can take everything, a lot of things. It's the kidney that we need to preserve. All right. So it's another algorithm. You can see this. I believe these cards are available to the staff. Otherwise, if you don't have or have not seen, how do you consider culturing? You culture a patient if they have symptoms, right? Well, what if a patient is old and they might not be able to communicate their symptoms? So something should be prompting you to do the culture. Could it be a white count? Possibly. But remember that in older individuals, 67, actually you shouldn't say 60, 70 or 80 plus people, or people with dementia and others, can actually also have asymptomatic bacteriuria, or can have non-infectious urine bacteria. They're not invasive. They're sitting there either in their urinary system or actually just outside and get contaminating. So, and they can have pyuria as well. It's really no consequence. It doesn't require treatment. So when we are testing urine, the question always should be, what am I going to do with the result? I mean, that should really be the question for everything. Every test you do, if you follow one principle and learn only one thing out of this call today, is that one question we should always ask is, what am I going to do with the result? You guys are in training. You guys are extremely smart. I can tell you, I've told that to my program director many times, that they will not hire me as a resident again. You guys are far more competitive than when I did it, right? So you guys are smart. You guys are good. You ask yourself every time you order one test, what am I going to do with the result? If it's not going to change your management, there's no reason to do a test, right? No reason to do a blood culture if it's not going to change management. If no reason, like for example, a person is dying, right, and you already have made them comfort care, it's not going to change any outcome. You're going to make them comfortable. Blood culture is not going to change that outcome. A urine culture in a person who's otherwise asymptomatic, and you may not do anything about it, it doesn't require treatment, it's not required for people. And that's kind of the basic key of all these things. Similarly, NHSN, hospital-associated Mrsa and Cdi are lab ID events. So slightly different though. They don't require a device, and a person who has positive blood culture with Mrsa after 3 days of admission, so after 3 days, and same is with C. diff, after 3 days of admission, their stool is positive for C. diff test, it will be considered positive. C. diff is known to be, C. diff can be a colonizer in stool. C. diff can be a colonizer in stool. So we need to be very careful in testing the stool. And there's usually a little bit more questions about testing the stool in these circumstances. You need to get approvals and so on and so forth. But and most of the places, and the reason really is we need to prevent any unnecessary testing of the stool itself. Blood culture positive for MRSA is actually probably one of the most serious consequences, because in my opinion as an ID doc, you wouldn't have MRSA bacteremia silently in any patient. You can have C. diff in a stool without diarrhea even, but you cannot have MRSA bacteremia silently. So after 3 days, if it occurs in a hospitalized patient, that is a serious problem. As a resident, what should you do if you found your patient has MRSA bacteremia? What should you be doing first? You get a call, I have MRSA bacteremia. Well, your patient has MRSA bacteremia. What are you gonna do first? Well, there are many things you can do, but tell me anything.
So Fatma in the chat said isolation. Karina saying make sure they're on antibiotics and vancomycin. And Javier saying check a TTE.
Perfect. Oh yeah, sorry. Now I pulled it up. Source control. Love it, love it, love it. You guys are using all my language here. All right, but also what I found as an ID doc is majority, if not all, but majority of these are associated with lines of some sort, right? So you look at the person who has lines, but also even peripheral lines. You know, what is the number one cause of peripheral line infections, or what do we call peripheral line infections?
Kieran saying phlebitis.
Yeah, phlebitis. Yeah. So what is the number one cause of phlebitis? Thrombophlebitis or peripheral veins. MRSA bacteremia or staph bacteremia, of which MRSA is an example. So I can tell you so many times I've gotten MRSA bacteremia consults. I will look at the patient and they would have an IV line that was removed because of infiltration. And I'll be like, infiltration, you say? Infiltration, huh? And that's where my ID doc hat comes out. But like that infiltration in my mind is the phlebitis. And the treatment changes once you diagnose the phlebitis. So bacteremia itself is treated for 2 weeks usually. But if you diagnose it with phlebitis, you might actually want to look at how deep the phlebitis is, that the vein need to be removed, or the treatment is extended to 4 weeks, right? So you need to look at peripheral lines. And that's where one of the most, for phlebitis, and I like Karen's point, is that you need to look at all these things very, very carefully. All of us agree with that point? We'll look at that, we'll start the Vanco, we'll call ID and all, but when you tell them, you'll make them cry if you tell them, I look at patients' IVs, all of them are intact, everything is fine. You will see how they react. You'll have fun with ID if you tell them these things. I'm telling you, inside secret. Like, they'll be like, oh, that'll be excitement, fireworks. All right, next slide. All right, I'm going a little slow, but I'm having too much fun. All right, so I can't move this thing. This one. All right, so IV care, and that's where what we were talking about is like looking at all these peripheral IVs is important. Patients shouldn't really have more than one peripheral IV, right? The care and it, like this, to me, I can tell you it has looked as background, but think about this. Patient on the right has all this blood in the line itself. It shouldn't be there. This is literally, to me, I can see staph growing there. I can't see staph, cannot see staph growing there, but you know what I'm saying, right? You can imagine it's a perfect culture media. Blood is the perfect culture media to staph for staph to grow. That's why it is there, right? This way. So you do C. diff measures, you put the patient in private rooms, you do use Gauss counts and so on and so forth. You use disposable equipment and do the DC terminal cleaning of the patient room, and then UV disinfection once patient is discharged. Everybody loves this chart in their slides because it's a stool chart, Bristol stool chart, and And then you can have a lot of fun about classification of different stools. And also, I'll leave it to you guys to just review this on your own. To me, lab will reject type 1 to type 4 stools. The way my lab micro director who trained me told me that stool that they will accept for C. diff needs to conform to the form of the container. So like you can just tell which will not or which will. Okay, my God. All right, too embarrassing. Moving on. All right. So C. diff algorithm, do not test the stool if the patient does not have unexplained diarrhea. That's the major thing. The other things you can always look at to limit PPIs, limit antibiotics. So many times, and that's another thing I want to raise with you guys, is many times I see people are on amoxicillin or augmentin or zosyn or stuff like that, and they are cefepime, stuff like that, and they have diarrhea. The moment they have C. diff diagnosed, the cefepime and all other antibiotics are stopped immediately. And I always ask myself, if this was stopped earlier, like what happened that day? Only C. diff made you change it? Not you, but like, so we should every day we should look at antibiotics as the cause of the diarrhea that's going to happen tomorrow, right? And think about stopping the antibiotic to prevent that diarrhea from happening tomorrow. So you can impact the future. You are our future. All right. I like this audience. Doesn't say anything to me. I love it. All right. So so there are recommendations. I've discussed most of them already. You need to make sure the patient. It's another funny story. I had a patient complain to me that they had diarrhea, and I got very worried. And I went into all this diagnosis, and ID diagnosis for diarrhea in a patient who's getting admitted. It wasn't even C. diff of a patient getting admitted, right? It was like huge. He had traveled, he had done so many things, came from Japan, but before that was in Korea. It was like ID doctor's dream. I was like literally having the time of my life. I was dead. I was like, oh my God, this is gonna be so crazy. And then I asked him accidentally that, okay, so how do you define diarrhea? And he told me he had loose stools 3 days ago. And I'm like, how about yesterday? It was fine. Today it was fine. I'm like, all right. So people's definition of diarrhea can be different than ours. The lesson learned from me, as a very excited young ID doc at that time till today, is that I always ask one question, like, how many loose stools you had in a day? So you can standardize that, and you can go crazy. You can give them the Bristol stool scale. What kind of stool was it? But you don't have to. So surgical site infections. I believe this is more of a medical resident call, right? So I won't get into too much detail into these, unless I'm mistaken. All right, let's see if there are any. All right, so surgical site infections, 30 days to 90 days, depending on if you implant something, that we surveil infections for 90 days. There are methods to reduce infections for surgical site infections. Those are very focused for surgical care of patients, pre-op care, CHE bathing, colonization or decolonization, and closing techniques, interior oral care. There's a lot of stuff that we need to do to prevent infections. VAE VAP bundles are actually more technical bundles than infection control bundles, but elevation of the bed, all these pictures, sedation, vacation, getting people better, PPI prophylaxis, and oral care, all a part of these bundles. We almost always need to look at patients who have, for example, who have central lines versus who develop infections with central lines. So the denominator is how many people had central lines. So this is a little bit complicated definition, but that can impact how the the cost to the patients are. Now, these costs are estimates, and they are grossly underestimated to the hospital costs themselves. The CLABSI, for example, can cost the patient an extra $45,000. CAR-T about $1,000 maybe. I don't think that's true, but I know that with the penalties that we have, I've seen hospitals with 11 CAR-Ts ending up, or CAR-Ts, ending up having greater than $1 million in penalties, because, and if you just translate 11 CAR-Ts equals to $1 million in penalties equals $100,000 per CAR-T that was penalized. The definitions are crazy, and to be honest, I don't want you guys to think about anything more global. I think your patient in front of you is the most important patient, and that's where we need to focus on. For infection prevention, we look at all these things, but what our expectations, our hopes from you guys really is that we are doing adequate, important diagnosis and reasonable testing, not unreasonable testing, not aggressive testing, because aggressive testing is not always the answer. Testing more is not always the answer, although some people feel better if they get tested versus not, but that's different. I have a story for that too, but I won't get into it. So this is a CAR-T table for the health system, where Mount Sinai Health System is doing overall fine. If it is 1, that means we are at national average. Below 1 is great. Above 1 is bad. So health system and all the other hospitals, all the hospitals are doing fantastic. 0.5 or 50% less than the country. But C. diff, we have numbers on the wrong side. In certain hospitals, our number is 2, so we are twice as many infections. Are these all infections, and what is going on? So being a little bit more careful about testing people, or more precise about testing people, so that the infection prevention people don't bother you, it's gonna be extremely helpful. Similarly, how are the hospital compared in these SIRs as like observed HAIs over predicted? I think I have like 1 more minute left, so I'm gonna try to get through this real quick. When the hospitals are performing at the bottom 25%, CMS cuts about 1% of their money being given to the hospital. 1% seems like a pretty small amount, but what is 1% of the hospital budget? Any takers? I'll give you a little bit of example. Is it 100,000? Is it 1 million? Is it 10 million? So hospital budgets, it depends on the hospital size, but majority of hospital budgets are about 10 to 15 million, depending on the size of the hospital. Like if for Mount Sinai Hospital, their budget is probably almost billion B with a B, or $600-700 million, right? Their 1% probably is going to be 7-8%, $7-8 million, right? Versus hospital of MSW size, their budget is probably 16-17 million, and so, or maybe 100 million or something like that. 1% would be 1 million. Profit margins of hospitals are within 1 to 2%. That's how tight the profit margins are. The CMS cuts 1% of money given to the hospital, which might actually be their profit. So the hospital can go into loss because of this. It's way too technical, but it does affect hospitals adversely, but it makes hospitals think about these infections more critically. And that's why people get involved or interested in it. But I think the bottom line issue really is not HAIs. It's like Mount Sinai Hospital, for example, got $4 million in penalties or payment reductions. I think in fiscal year 19. That is not what we should we should probably think about. What we should think about is what is right for my patient, right? What is right for my patient is what is right for my patient is accurate diagnosis, not over diagnosis. Everything moves, doesn't need to be cultured, right? But it's better to appropriately culture and adequately treat. If I, as a normal person, am walking around without central lines and peripheral lines, as well as catheters, and my patient has all these three things, can I get him to normalcy by removing all these lines and catheters? That should be my goal. I am not on antibiotics, although you culture my sputum might grow MRSA, right? I'm not on antibiotics. So not everybody with cultures positive for MRSA needs antibiotics. And think about that. And you can stop antibiotics earlier on and don't need all these lines and whatnot. All right. And I'll not bore you too much on these things anymore. But I think all these things, reducing all these infections are critical, are important, and we have achieved them before. I think your role as the providers at frontline providers needs to be to help in accurate diagnosis and prevention of infections. We have our dashboard in Mount Sinai apps under infection prevention dashboard, and there are charts that are available. I'll ask Chrissy to send it to the chiefs so you can have all these slides available to you as well. You can help infection prevention. You can do ID. If any one of you got interested in doing ID or is interested in doing infectious disease or infection prevention, please let me know. I'm looking for people. We do wonderful stuff and we are really good people. Advertising myself here. All right. And these are resources. Just wash your hands.
Thank you so much, Dr. Javaid. If anyone has any questions, you can feel free to unmute yourselves or also post in the chat.
I actually have a question. Sorry. For CDI, how do we know that the excess of cases is from over testing and not from under testing and then propagation of this within the hospital from patients we did not test?
Right. So we do.
I think you muted yourself again, Dr. Javaid. Sorry.
Am I unmuted now?
Yes.
Okay. Yeah, you see, I didn't want to answer your question, so I kind of did this. No, your question is very, very good. Very good. And that's a question like, it's a really important balance for us to kind of establish. People have C. diff. They get admitted with C. diff. We monitor C. diff. We monitor diarrheal illnesses. And we get involved in these conversations about C. diff. For example, if somebody says no to you, I'm just giving you an example. Like, so if somebody says no to you about the diarrheal illness your patient had and says, let's stop antibiotics and all that, C. diff is not going to go away by just not testing for it, right? If you don't test it day one, you'll need to test it day 2 or day 3. The diarrhea will continue and continue to worsen. It, like, you might be able to hide one infection or two at the most, but the outbreak like this is not a sustainable thing. Like, people will find it. We will find it. Lastly, I would rather know than not know as an infection preventionist. Part of my goal, I know for a fact a case we had with C. diff, a person who had her spinal, she had rods in her spine placed for correction and all that. A 70-year-old lady went to our rehab unit. Her roommate had C. diff. This person developed C. diff and actually died. So I have seen people die of C. diff. I have seen people die of C. diff after 1 week of receiving cefazolin. not meropenem, not fancy drugs, but even simple antibiotics. So I know this is a deadly illness, and you know it's a deadly illness. I would, I totally get what your point is, and we should never be under testing. We should be appropriately testing. So how acute the need of C. diff testing is. A white count of 14 with no other symptoms doesn't automatically mean we should do C. diff testing. Although a person who has abdominal symptoms and has diarrhea, more than 7 stools a day, for example, something like that, that makes sense, testing is appropriate, right? So I think that's a balance. But I don't think, and I totally agree, like, I don't think there should be any reason not to test people if if it is indicated.
Thanks.
Any other questions?
Thank you so much, Dr. Javaid.